CTSNet friends. My name's Joel Dunning, and this podcast aims to give you an intravenous injection of everything that's new and exciting in the world of cardiothoracic surgery this week. And this week we've got a really packed edition, some huge papers. We've got the world's first randomised trial of port access mitral versus sternotomy. We've got the AATS lung cancer guidelines, a huge tome that sets the stall for the next 5 years of lung cancer treatment, together with an interesting paper that sheds some extra light. On the videos, we've got a mitral and ravitch repair. We've got an interesting step-by-step series about removing a cannula, and Emily Farkas does a phenomenally great job of doing an interview all about humility in cardiothoracic surgery. So don't go away, and let's get cracking with the CTSNet podcast. The first paper we've got for you today is on our Jan's news section on the CTS website, and it is entitled Minithoracotomy versus Conventional Sternotomy for Mitral Valve Repair, a randomised clinical trial. So yeah, this is the world's first randomised trial of port access versus sternotomy surgery for mitral repair. That is fantastic, and it's been done by the wonderful Professor Enoch Akoa from my very own unit in the UK. Now the UK is really well attuned to doing randomized trials in surgery. We just have lots of the ingredients that allows randomization, which is really fantastic. We all work for the same team, and the NHS has a good fund for this. So that's why studies like this are possible in the UK. And Enoch has a proven track record. He's already done a mini sternotomy versus full sternotomy for AVR randomized trial called Maverick, and he moved on to this fantastic study. So this study used 10 centres in the UK. They used absolute experts of port access mitral. I think you had to have 50 before you could join this. And different to their AVR study, where the surgeon either did a mini or a full sternotomy, because there weren't many really good port access mitral surgeons in the UK, they decided to say, okay, we're going to randomise to a surgeon that does port access mitral or a surgeon that's expert in sternotomy and mitral repair. So the other really interesting thing about this study is that the primary outcome measure is an SF36 physical function score 12 weeks after surgery. So they ask the patient, how are you physically functioning? So that's what the NHS wants these days. They want a score that's related to the patient's outcome. So really novel, brand new stuff. I do encourage you to read the paper in full because it really is quite stunning. So it's from January 2016 to 2021. Yep, right through the middle of COVID. Poor team. Well, they really did a great job. There was a slowdown, but then they got their allocation. They got 330 people randomized into that study, 166 to the port access group, 164 to sternotomy. Amazing job, really well done. So the outcome measures, so the outcomes were very good in both groups. So the SF36 physical function score was really excellent in both groups, and actually there wasn't a clinically significant difference. But where this paper really comes in is that it proves that port access mitral is completely as safe as open repair. You're not taking shortcuts, you're not doing bad repairs. B, it showed really good outcomes, really low levels of complications. And C, it showed a very high rate of repair versus replacement. Many studies show that the repair rate is about 60% in national databases, but the repair rate was 96%. So this study shows if you take experts in their field, you can really get huge repair rates. So take a look at that. Really good study. If you do port access, it really does support that you can do it safely and get excellent outcomes, and you can leave it to the patient. What would they like to have? Great study. What do you think? If you could drop us a comment in the comments below, let me hear. Are you going to change your practice? Are you going to go back to sternotomy? Are you going to go to port access mitral? Does this relate to robotic mitral? Could that be better still? Who knows? I'd love to hear your thoughts. So the second paper we've got for you is the huge American Association for Thoracic Surgery expert consensus statement on the treatment of lung cancer. This is a really big document. They got a huge expert consensus panel going. It's a stellar list of everybody you've ever heard of in lung cancer. So Brendan Starrs was senior author. Binyam Kidane is first author. We've got Scott Swanson in there, Yolanda Coulson, Tom D'Amico, loads and loads of our very best people. So and they've done a huge job. They did loads and loads of chapters. So do check it out in the JTCVS this month. Published in June. I think the basis of this guideline is the shocking fact, as they state in the introduction, that even in stage 1 and 2, the recurrence rate is 20 to 25%. So a quarter of your patients are going to recur if you just do an operation, even at the early stages. And then it says, once you get to stage 3, recurrence is 50 to 70%. So the overall message of this whole guideline, I think, is we cannot do surgery on our own. I think the days of saying to our patients, we're going to operate and then you can go home, you'll be fine, are long gone. We are a multidisciplinary team. So that is the tenet of it. So there was a huge amount of focus on neoadjuvant chemotherapy and immunotherapy. Interestingly, they still say that really lobectomy is still the gold standard. They did extensively talk about JCOG and CalGB. CalGB hadn't quite been published when this went to press, but they did say that below 2 centimeters, there is an okay argument for sublobar resections and segmentectomies. And they did talk at great length about it's so important to get intraoperative frozen section to make sure that they're N0, because it is a big problem if you have N1 disease and you don't do the right operation, because the recurrence rates are so high. And they said even with these stage 1 cancer trials that the recurrence rate still is very high. So they then went through Checkmate 816 and Iron Power 10, looking at the now FDA approved indications for neoadjuvant treatment. So and these basically are the studies that show that nivolumab and acetazilimab are both really, really important staples of treatment now. And really we are moving to neoadjuvant treatment. They did a really good job of summarizing how us surgeons are always really worried, are we going to lose our patients? Are they going to be really difficult to operate? It was not borne out in these studies, and they make some strong recommendations for moving towards neoadjuvant treatment with chemotherapy and immunotherapy followed by surgery. And these studies are really very impressive. They really do show reduced recurrence rate. And Checkmate 816, for example, there was a 24% complete pathological response when you came to take the tumor out versus 2% if you didn't use the immunotherapy with chemotherapy. So they're really increasing disease-free survival in the groups, 31 months versus 20 months. So these are really important studies. They're changing practice, and these guidelines say you must change practice. So take a look at them. We now no longer live in a bubble. Anybody from stage 1B with a tumor bigger than 4 centimeters is basically going to have probably neoadjuvant treatment now going forwards, and these guidelines are there to guide us. So well done, Brendan Starrs and the AATS, and go check out the JTCVS this month for full details. The third paper we've got for you, again, casts some interesting light on some of the recommendations on the AATS paper. It's called Wedge Resection versus Lobectomy for Clinical Stage 1A non-small cell lung cancer with occult lymph node disease. So Joe Chikwi selected this as the best paper of the Annals of Thoracic Surgery this month, so go check it out on the AATS Annals of Thoracic Surgery website. And this paper comes from the Ohio State University Wexner Medical Center. Robert Merritt was the senior author, and they went and analyzed the National Cancer Database. And in that database, there are 5,437 patients with clinical stage 1A T1 disease, and out of them, 2,800 were upstaged to N1 disease when they had their operation, and so those 2,800 had lobectomies, and then another 128 patients that were upstaged had a wedge resection. And go figure, no surprise, but if you had a wedge resection and you had N1, you did much worse than if you had a lobectomy. So now what does this mean? Well, firstly, this is a 5,000 patient database of clinical stage 1 disease. So that's a big group. And out of that 5,000 patients, 62% had occult N1 disease. 62%. 62% of people you thought were going to be N0 were N1. That is huge. Interestingly, 37% in that database that were clinical stage 1A had N2 disease. It shows the absolute vital importance of lymph nodes. There is a mantra in thoracic surgery that thoracic surgery is a lymphadenectomy with a lobectomy at the end. And I think this paper really shows how important those lymph nodes are. And again, if you're going to start doing segmentectomies or wedges for very early cancers, you have to do intraoperative frozen section of those N1 nodes, because you do not want to get it wrong. This paper is basically saying if you get it wrong, you're going to get much worse outcomes. So it was, if you had a lobectomy with N1, you had 70-month median survival versus 36% if you only got a wedge. So you really are harming a patient if you haven't done a lobectomy with N1 disease. So really interesting. I think we're all learning how to balance our sublobar resections in fit people versus lobectomies. And these two papers really do provide us with a lot of guidance. So with that, I'm going to hand you over to CTSNet to see what's on the website this week.
Submissions are now open for CTSNet's annual Innovation Video Competition. The competition rewards surgeons at the cutting edge of cardiothoracic surgery with a $1,000 cash prize, a prominent feature on CTSNet, and an exclusive interview with the judges. Submit your videos showcasing creative solutions, novel surgical approaches, and technological advances in CT surgery by August 31st, 2023 for a chance to win. For more information, visit ctsnet.org/innovation video competition.
Okay, so we've got 3 really fantastic videos for you this week on CTSNet. Go check it out on our front page. The first one is an interesting one because how often have you had somebody needing heart surgery that also has pectus excavatum? Well, it's not quite so rare, really. It does happen occasionally, and I think the wrong answer is to do nothing about it. And there's a beautiful video about how you can do combined surgery. So this is from Emory University. Joshua Rosenblum and Maureen McKiernan submitted this brilliant video, and this is about a mitral valve repair in a 13-year-old patient who's got Marfan's. So in this video, they show us the operation in beautiful detail, and basically they start the Ravitch repair. They take out all the costal cartilages, 3rd to the 8th on the left hand side. They remove them. They then cut all the muscle, and then they insert the retractor between the sternum and those stumps to provide a really very good view of the mitral valve, and it's all shown on the video. They do an annuloplasty, then they do a sutured repair of the valve. Of note, the Haller index of this patient was 30. Actually, looking at the picture they provide, it looked like the sternum was almost below the vertebral body, so that would actually give it a Haller index of infinity. But take a look at it. I mean, it was unbelievable. This person was seriously severe. You could not have not done the Ravitch operation. But anyway, they did an annuloplasty ring. They sutured a cleft in the posterior leaflet. Then they found there was a little bit of residual leak on testing, so they did an Alfieri stitch in this patient. Got really nice results, very nice. And then once they wean off bypass, they then continue the Ravitch repair. They do a horizontal osteotomy. They use a plate to straighten the sternum, and then they use a bio-bridge underneath the sternum to hold that above. I wish I could get one of those bio-bridges. They're not available in Europe, but they're really effective things. They absorb in 2 years, by which time this kid's chest will be solid. So lovely job, really interesting. And if you ever presented with a case like this, do consider doing combined surgery. But I'd be interested to know your thoughts. Maybe you should be doing a NUS after this, or maybe a Ravitch is best. What do you think? Pop your answer below. The second video we've got is in our step-by-step series. CTSNet are trying to create a set of really interesting step-by-step videos, quite basic procedures or usual or common procedures that you can go straight to as a really interesting resource for you. And this one is from Paul Modi, an absolutely fabulous surgeon from Liverpool in the United Kingdom. He is our most established port access mitral surgery, and he's a robotic mitral surgeon as well. But in this video, he shows us a step-by-step way of how to insert and remove their SVC cannula. The really interesting thing about this is everything they've stopped doing over the years, because they've got really good at it because they're doing it all the time. And they said they no longer have an assistant or scrub nurse for doing it. They just do it themselves. They get rid of the long guide wires that come in the dilator packs. They now use shorter wires. They don't use the dilators anymore because the Bio-Medicus cannula has a dilating tip. So they just use that to dilate straight off. And they don't vary the depth anymore. They just bang it to 12 centimeters because that reliably sits at the tip of the SVC and is above the Chitwood clamp. So I thought that was really interesting. The other really interesting thing is on removal, they don't press because they think that pressing the internal jugular on removal leads to thrombus formation. All they do is snug a purse string and leave it. There's a little bit of a hematoma, they say, but it's much better than pressing. I thought that was really interesting. Well done, team. A really good video. Nice and quick. Definitely worth 10 minutes of your time. The third video we've got for you is an absolutely wonderful video from Emily Farkas and Loretta Ehenwezi. This video is all about humility in cardiothoracic surgery, and if you have 10 minutes in your day anytime this week, I strongly encourage you to go and have a look at this because it really is fantastic. Loretta actually presented this at the AATS and gave a speech on humility and what is all this about. Well, it's all about listening to your patient. What is the background of the patient? Are you going to do an operation on this patient who may not have the background to recover? A really interesting discussion was had about female patients that come who don't speak native English and their husband's doing all the talking for them. Should you accept this? Should you not? And they give a really interesting discussion about this. And so it does bring up some really interesting things, listening to your patient, knowing their background. And the other thing is, what are their expectations? There have been lots of studies about people having CABG surgery electively. Most patients think that they had their lives definitively saved by that operation. But did they really? Did the patients really understand that in many cases there's only perhaps a 5% 5-year mortality benefit for elective CABG? Does your patient understand if they're having an asymptomatic mitral repair early, that this is not necessarily life-saving? They do have other choices. So yeah, documenting this and understanding what your patient understands, I think, is really, really important. And this video did a great job of showing all that. Well done to fabulous Emily Farkas and Loretta in that video. So those are our servings for you. I thought they were really, really interesting. Now there are some really good events going on around the world. So let me tell you about some of these. So in Halifax in Canada, they're having the 3rd Heritable Aortic Disorders Symposium. This is run by the Genetic Disorders Association of Canada. And actually it's quite interesting because it brings together clinicians and patients in a 2-day conference in Halifax, all about aortic conditions. And it looks like it's really interesting. It's going to be really good. It's on the 24th and 23rd of June, and check it out. It is in person, so you would need to get there, but it should be pretty good. Really interesting AortoVascular Symposium is going to be held in Barts on the 29th and the 30th of June. It's called the Barts Symposium 900. And can you believe that Barts Hospital is 900 years old this month? To commemorate that, they're having a series of very impressive symposiums, and this one couldn't be more impressive. So for aortic disease, they've got Joe Kiselli, Michael Border, Martin Cerny, Duke Cameron, Ung U, and John Yap. They've got some amazing, stellar people doing some brilliant talks. Again, you have to be there in person, but I'm sure it will be very much worth going there for this in this amazing august Barts, which is 900 years old. And finally, a really interesting and novel thing going on by EACTS is EACTS Case Corners. They're doing a completely online virtual courses, and this one's on June the 29th. Now, you can submit a case if you like. The residence committee will select and see if your case should be discussed. And they will discuss these on June the 29th. The other really nice thing is it's only a tenner to join. And if you do 2 sessions, the second one's a $5, and so on. So it's really cheap, it's really good. You'll get your cases talked about, and it's all online. So check that out at EACTS for Aortic Dissection Case Corner. So we move on to our last two topics. The first one is, where's Diego? Diego, the world roving surgeon, teaching the world to do thoracic surgery. Where is he this week? Well, this week he's traveling around Germany. He's been in Karlsruhe and some other centers as well, doing loads of uniportal VATs and RATs. And I think he's in Germany for a couple of weeks now because he's going to be at the Potsdam Uniportal conference the week after. So well done him. And finally, our honourable mention goes to Tom Varghese and David Cook. I've been loving their fantastic STS podcasts called Same Surgeon, Different Light. They're absolutely wonderful. They get under the skin of the surgeons you've already heard of. They talk about their background, how they've grown up, and their views on life. They really are wonderful. They're definitely worth 20 minutes of your time when you're out running on a weekend or driving to work. They've done some really stellar interviews. They've had Daniel Molina, Mark Owender, Joe Chikwi, Sarah Pereira, Bartley Griffiths, really amazing, stellar people. So check that out, and well done, Tom Varghese and David Cook. You guys are our heroes this week. So that's all we've got time for, and thank you for making it all the way to the end of this podcast. And if you have any thoughts or suggestions, do get in contact. We're getting suggestions all the time, so if you've written a paper or you want us to talk about something, just let us know. And thank you very much from myself, Joel Dunning, and everyone at CTSNet. See you next week on the CTSNet Beat podcast.